Hello everybody to the first talk. I welcome everybody to the first talk in the series on neurophilosophy, a talk series that some of you may not know is actually hosted by the Rotman Institute of Philosophy and the Brain and Mind Institute here at Western, and it brings together twice a year the two institutes with distinguished scientists or philosophers who talk about issues that are of interest to both disciplines. So I'm very pleased to introduce today's speaker, Dr. Hugo Critchley, who is a chair in psychiatry at the University of Sussex in England, and he is also one of two directors of the Sackler Institute or Centre for Consciousness Science at the University of Sussex. This is an institute that was just founded relatively recently in 2010 by the Sackler Foundation, and this is actually an interesting parallel between the Rotman Institute. So where in both institutes it seems to be that philanthropy has really made a big difference in terms of to allow for interdisciplinary work. Dr. Critchley trained in physiology and medicine at the University of Liverpool, then received his doctorate in psychology at the University of Oxford, and then he became a specialist in psychiatry and neurology, training at some of the best institutes in that country, the Institute of Psychiatry as well as the Institute of Neurology. And subsequently he became a principal investigator at one of the leading imaging centers in the UK, the Wellcome Department of Imaging Neuroscience, part of UCL, in London, where he held his position until he took up his current position at Sussex. Dr. Critchley's research program addresses a topic that I think has a very prominent history in philosophy, neuroscience, as well as the psychology science, and that is the interactions between body, mind, and brain, ultimately. And his research, broadly speaking, addresses this from the perspective of the role of the autonomic nervous system in cognitive phenomena and emotional phenomena that are traditionally linked to the central nervous system. And I think it's this interface between the two, while bringing in also the phenomenology of emotions, feelings, and the sense of self, as he will tell us about, that makes it particularly interesting and a great topic and for this particular talk series. So Dr. Critchley is a very prolific scientist. He has more than 150 papers on his CV, more than 20,000 Google citations, and perhaps his most influential paper is one that came out in 2004 called Neural Systems Supporting Interoceptive Awareness, that in itself has more than 1,700 citations, and that's in fact a paper that I became familiar with when I started hearing about Dr. Critchley's work. And it is really a sort of a foundation in neuroscience as to neural mechanism of interoceptive awareness, an awareness that has a particular role in feelings. So we are really excited to have Dr. Critchley here, and I look forward to the talk. Thank you very much.
Well, thank you so much for a wonderful, very kind introduction, and for inviting me here. It's a real pleasure to be here, and an honour to speak to you all. I want to talk about interoception, as Stefan alluded to, and put it in the context of studies of emotion and how it may have implications for understanding aspects of selfhood. And I want to present data that refers to how the heart, in particular, as an interoceptive, a source of interoceptive signals, influences aspects of emotion and perception. There's a long history to thinking about how the body might influence mental processes. Hippocrates and his followers in whatever it is, 200 BC, they were medics, and they dissected and did experiments, and they argued that actually the source of our pleasure, merriment, laughter, amusement, grief, pain, anxiety, tears is the brain. Diaphragm nor heart neither take part in mental operations. So they're stating really that everything goes on in the brain, the body doesn't really matter in mental processes, which suggests that there's already an argument about that going on before they made this statement. But it's really Aristotle that took an alternative view and argued that the brain is not responsible for any of the sensations. The correct view is the seat and source of sensation is the region of the heart. The motions of pleasure and pain and generally all sensation plainly have their source in the heart. So two very opposing views, and Aristotle was quite influential in Western thinking as directed from Rome over ensuing years. So the heart is the visceral organ, it's in your body, it's controlled automatically, autonomically, but reflects not only the needs of the body to move and to execute action and adjust the demands of perfusion to meet postural changes, it also reflects mental processes. And so you know, poets and writers talk about emotional sensations having effects on hearts jumping a beat when you see someone that you love and so forth. The way in which the heart communicates to the brain at a neural level is quite interesting. Every heartbeat is signalled to the brain by a barrage of activity from stretch receptors in the great vessels that leave the heart. So as the heart ejects blood into the aorta and up into the carotids, these stretch receptors, known as baroreceptors because they're measuring pressure, send pulsatile signals to the brainstem. And in the brainstem, these signals trigger reflex control of blood pressure, so that if you have a particularly large signal coming from the baroreceptors reflecting a strong output from the heart, then depending on how the baroreflex is set, the next heartbeat is delayed slightly and the vessels in muscle vascular beds dilate a bit so that you adapt to the increased blood pressure on the preceding heartbeats by decreasing blood pressure on the next heartbeat. And this mechanism keeps us well, adjusts us to, makes us able to adjust to postural changes and to other demands of exercise. And it's also controlled by descending mechanisms that set the level of the baroreflex sensitivity, so that if you need that extra drive from the heart, you need the heart to beat faster and stronger to meet the needs of running away from a bear or something like that. You can suppress the baroreflex and heart rates and blood pressure can rise together. And that is essentially what cardiovascular arousal is about. It's about suppressing the baroreflex and allowing heart rate and blood pressure to rise together. The same input from the heart, neural input from the heart, also travels up the neuraxis and informs the rest of the brain, the motivational systems in brainstem and centres in limbic and cortical regions. It tells the brain when the heart is beating and how strong the heart is beating, but it does so in this very pulsatile fashion with every heartbeat being signalled by a barrage of neural inputs. We can tap into mechanisms, this channel of cardiovascular arousal by using the facts that these signals occur in pulses. So around systole, so this is the ECG, and the R wave is when you get a wave of electrical depolarization across the myocardium, across the surface of the heart, which makes it contract. So everything before the R wave is diastole, it's before the heart is contracting, and then the heart contracts after the spread of electricity across the heart. The T wave is the recovery from that electrical spread, and around that time blood is ejected from the heart into the great vessels and triggers this barrage of neural firing to the brain. And therefore whatever happens before systole is diastole, the baroreceptor quiet period between heartbeats. And we can tap it into the same signals that signal when the heart is beating fast and strong by presenting stimuli at different phases of the cardiac cycle. So if we present phase stimuli briefly at systole, The presentation occurs when the heart is signalling to the brain it's beating and how strong it's beating. And if we present a face in diastole, it's when those baroreceptors are quiet. And the thing that I want to draw attention to is a relatively recent discovery we've made, which is that if you present fearful images or threat stimuli at systole, you get an enhancement of the processing of that threat. So that if you're looking at fear faces, you get an increased rating of how fearful that face is if it's presented at systole compared to diastole. So this is when the heart is signalling to the brain. This is between those signals. And that effect seems quite specific to fear. We don't get it for neutral faces. The other observation that relates to this is that you also get an effect of heart timing of these baroreceptor afferent signals on the detection of fear stimuli. So that this is a paradigm called an emotional attentional blink task, where you push perceptual attention-dependent resources to the limit. You're trying to detect two targets in a series, rapid series of visual mask images. This is a house. You try and detect the house and remember what the house was, and then this is the face. And if that face occurs around 300 milliseconds after the first target, it's very hard to spot. However, if that face is emotional, it's a bit easier to spot. It breaks through to perceptual awareness, and that's the attentional or emotional modulation of the attentional blink effect. The fact that emotional stimuli seem to overcome this attentional blink, as it's called, this failure to recognize the second target when you perceive the first target. And what we've shown that if you present the second image at systole, when these baroreceptors are signaling from the heart, you enhance the processing of fear stimuli. You're much better at detecting fear stimuli at systole compared to diastole, and that heart input has no effect on other emotions, or if anything goes in the opposite direction for neutral facial expressions. So together, the perception, intensity rating and detection of fear stimuli seems to be specifically enhanced by these cardiac receptor signals, baroreceptor signals. One other observation relates to the fact that not everyone shows this effect. So these were subjects in the first version of this task, 20 subjects, 3 of them show no effect and 2 of them show effect slightly in the opposite direction, which means that there may be something in this mechanism that can speak to individual differences in aspects of emotional processing, particularly in relation to threat, that may be of clinical significance, and that's an interest of mine in looking at. I wasn't supposed to quite do that, but so this is supposed to be mental processes, cognitions, and so forth. We know that mental processes are dependent on the body state. If we're hungry, we see food differently, we remember food differently, we process the environment differently than if we're not hungry. That's supposed to be a spider, yeah? And this dependence on the body was also proposed to be the basis of all emotional feelings, more or less, by William James and Carl Langer, who noted that pretty much all emotions trigger a change in body states. If you don't get that change in body states, you can't really say that an emotion occurred, and consequently, those emotional feelings that colour our perception of stimuli must arise from the body. An extension of that proposes that different emotional feeling states may have different patterns of body response, and that's actually been the target of much of the criticism of the James Langer theory of emotion, rather than the initial proposal that that body state matters. Schachter and Singer version of this story is that the body state, a change in bodily physiology, may trigger the onset of an emotion and add to the intensity of emotional feelings, but actually it's how you interpret the cause of that change in body states, what goes on in the environments, that determines which emotion you feel. Your heart may skip a beat because you see a spider or because you see someone you love. So different emotions may be triggered by the physiology, but are ultimately defined by the context that that physiological change may occur. Interest in how the body influences mental processes was revived 25 years ago or so by Damasio and colleagues, who noted the association between problems in generating and perceiving internal body states as a consequence of damage to the frontal lobe and deficits in emotional behaviour and aspects of decision making. So he proposed the somatic marker hypothesis, which argues that bodily changes have a biasing effect on aspects of cognition as well as emotion, and then drew attention more generically to the role in which body states builds up conscious representations, emotions, and cognitions from this quite low biological level. The way in which internal body state is controlled at a neural level is by the autonomic nervous system, which has two branches. A kind of sympathetic fight-flight response is triggered by the sympathetic nervous system, which increases heart rate, increases blood pressure, and this is countered by the parasympathetic nervous system, which is more rapid because it comes from the brain, and that will decrease heart rate and ultimately lower blood pressure. So most organs in the body are supplied by both sympathetic and parasympathetic nervous systems, and these act to control and guide automatically the inner state of arousal of the body. The spinal cord and the cranial nerves are also the source of feedback about bodily arousal to the brain, and that highlighted the vagus and the glossopharyngeal nerves as the ones that are sending signals from the great vessels to the brain about when the heart is beating. We've done lots of studies looking at the central correlates of peripheral physiological arousal across multiple different challenges to mental state and physiological state, and broadly speaking, I've come to the conclusion that a very important region is this dorsal supragenual anterior cingulate cortex, which seems to be a driver for sympathetic changes in the periphery. This shows a study not from our laboratory but from Tor Weger's lab, where they challenged people with an emotional challenge. They got them to prepare a speech, and that increased heart rate. It's a scanning experiment. They gave people the words that they had to prepare the speech about. That increased the person's heart rate as they got worried about the fact that they're going to be evaluated on the speech, and they had to do it as well as possible. And then they were told actually they're not going to be evaluated on, and they didn't need to prepare the speech after all, and that decreased heart rate. And they found that what they call social evaluative threat of speech preparation increased activity in dorsal anterior cingulates, which mediated the increase in heart rate that was observed during speech preparation. And there's a corresponding decrease in ventromedial prefrontal cortex that also was responsible for increasing the heart rate. So the combination of a drive from dorsal anterior cingulate and a withdrawal of ventromedial prefrontal cortical activity resulted in emotion-induced cardiovascular arousal. And pretty much all our studies, more or less, on cardiovascular arousal would argue that there are generators in the behavioural context of autonomic arousal responses within anterior and dorsal anterior cingulates, often with brainstem and periaqueductal grey regions. Amygdala, depending on the task, so during emotional challenges we tend to get amygdala activity, and often we get this withdrawal of ventromedial prefrontal cortical activity that we've interpreted as being a vagus nerve, a parasympathetic withdrawal, which also increases heart rate. So that's a summary of probably about 20 experiments relating to central generators of cardiovascular arousal. But that's not really what we want to talk about today. We want to talk about interoception, which is about sensing the internal states of the body. So one of the predictions of these peripheral theories of emotion is that different body states produce different feeling states, and that's relevant to emotion. And we've tackled this in a number of ways. We've looked at patients that can't generate bodily states of arousal. We've looked at people with spinal cord lesions with damage to or perturbations of vagus nerve function, which include people with implanted vagus nerve stimulators, and tried to map how the afferent input from body states reaches the brain. One way we've approached is to get an artist who is with us in the lab to create some pretty horrible videos to induce a sense of disgust in people. So we were going for a kind of disgust that makes people faint, so bloody disgust, and a kind of disgust that makes people vomit, a nauseating disgust. And I haven't loaded the video, so I can show you. Yeah, I mean, these are quite challenging for non-medics, and what we were trying to do is look at which brain areas predict not so much the response to the video, but actually predict the response in the body. We measured the electrogastrograph, the electrical signals from the stomach. And when you start feeling nauseous, the normal 3 cycles a minute electrical wave you get in the stomach disappears, and you get a tachygastric response. Stomach starts churning a bit. And when you start feeling faint, you get changes in heart rate variability and sympathetic activity. And what we found when comparing the two types of video, we got bloody disgust actually in left anterior insula associated with the increased activity in that region, and this nauseating disgust in a region in the right insula, dorsal insula. But what was perhaps more interesting is those areas that maps the physiology. In this case, the nauseating disgust, the changes in the electrogastrograph, also predicted the subjective feeling states of nausea to that particular class of videos. So disgust evoked by nauseating videos was predicted by the mapping of gastric physiology or the correlates of that in insular cortex, particularly on the right side. And similarly, during nauseating disgust, we got the area that seemed to map changes in heart rate variability, withdrawal of parasympathetic tone, the area that seemed to that correlated with that in terms of brain activity, also predicted the magnitude of disgust to the nauseating video, to the bloody videos. The same area, the map the physiology predicted the subjective feeling states. So there appears to be a patterning of autonomic responses, even within a single emotional class, if you call disgust one emotion. There's a link between subjective emotional experience and bodily response mediated through discrete brain subregions or regions. And that study, along with others, argues that insula may be a substrate for feeling states that arise from the signalling in cortex of bodily physiology. It wasn't the first study that proposed that insula was somehow involved in the readouts of physiology into some kind of conscious emotional experience, and this was explored in a number of contexts. Stefan referred to a paper we did in 2004 on individual differences in interoceptive ability. And the logic here is that people differ in the extent to which they're sensitive to their internal bodily states of arousal. If you're particularly sensitive, you're particularly good at detecting changes in your body, then you may be more prone to anxiety, you may experience emotional changes with more intensity for the same magnitude of physiological change, and there's also evidence to show that you're more sensitive to other physiological changes, including pain. But there's also positive aspects to being good at perceiving your body. You may, or there's evidence to show you're better at kind of intuitive motivational decisions, that you score more on empathy ratings or in empathy tasks. You may have an increased capacity for emotion regulation by having a closer readout of these physiological changes when induced by emotion. There's even data which I may come to on having a stronger sense of self as a consequence of having a very good access to your internal biological representation. So the ways of measuring interoceptive ability have really crystallized on heartbeat dissection, which is really about when you're at rest and not feeling a pulse, can you feel your heart beating, and how well can you feel your heart beating? And there's a spread of, depending on what test you use, of abilities in heartbeat detection. One of the tests is heartbeat tracking, where you hear a signal to start counting, period of time passes, told to stop counting, and you basically count the number of heartbeats you perceive over an interval of 45 seconds or so, repeat it over different intervals, and compare the number of heartbeats you feel and report during those intervals with the actual number of heartbeats measured using electrocardiography. And that gives a measure of heartbeat counting accuracy. Another approach is to play notes back with each individual heartbeats. So a series, say, of 10 heartbeats, you'd hear a note, and at the end of the series, you'd have to report whether those notes were in time with your heartbeats, or either time shifted, delayed by 500 milliseconds, or at a different rate. And that could be notes or flashing lights. And both these tasks have a lot of face validity and when field testing, but they're not psychometrically particularly strong, and have been a subject of some criticism, but nevertheless they're the best we have at the moment. So this relates to the imaging study that we conducted some time ago. We had people in the scanner listening to beeps over a series of 10 beeps, and if they saw a heart at the start, they had to report whether the beeps were in time with their heart or delayed. If they saw the word notes, they had to detect whether there was a very slight change in the quality of one of the notes they heard. And what we found is that people who performed this task showed more activity in right anterior insular cortex that predicted the degree of accuracy on this task when they're doing the interoceptive task compared to the exteroceptive, the note detection task, the control task. And the degree of which this accuracy was experienced by, was seen in individuals predicted day-to-day experiences of anxiety, and as did the anterior insular response, which together suggested that somehow this area was involved in reading out the experience of heartbeats, and that experience and the readout in insular cortex also predicted emotional characteristics, for example, day-to-day experiences of anxiety symptoms. And that functional imaging study was complemented by a structural imaging study, which also reported differences in the volume of this insular area, predicting interoceptive ability across a couple of questionnaires. This shows the data from the same study. There was a lot more data in that study, but most of it doesn't get reported. And one thing I want to draw your attention to was actually on this side, which is parts of the brain that were also sensitive to the correspondence of attention and delay. So if you're focusing on your heart or the notes, and whether there's a delay or not, the right frontal operculum going into right insular and areas like cingulate cortex seem to be sensitive to the matching of the notes that people heard and the timing of their heartbeat. That's relevant to heartbeat timing experiments. Anyway, so insular is sensitive to internal bodily signals. appears to enable a translation of bodily signalling into reportable experiences, which could be described as feeling states, which may be purely physiological or maybe emotional. And Critchley seems to support this comparison with between your own physiological states, so heartbeat timing, with what's going on in the environment, so the delay present in a node in this context. So I just want to return back to the observation I presented at the start, because this really I think it is for us an important finding, and to say the timing of individual heartbeats as signalled by cardiac baroreceptors influences the perception of fear. And I'll go into the backstory of that. There have been a number of studies over the years dating back to the late 60s looking at the effects of heart timing on various tasks. Usually reaction time tasks. The whole field to some extent got overly complicated and people moved away from it because one of the main outcome measures was actually a heart rate change, and it kind of ate into itself in having an outcome that was part of the design. But anyway, it's been noted for a while that if you give someone a pain stimulus in time with heart beating, then you get an attenuation of the perception of pain. You get attenuated processing of the pain, as shown with pain-evoked potentials. You get a reduction in nociceptive reflexes, and that's been argued to actually have some meaning in terms of the pathogenesis, for example, of hypertension. So if high blood pressure and high heart rate limits pain perception, then this may be a kind of a learnt mechanism that in hypertension. You can show this by augmenting the effect of baroreceptor activation using external neck suction. So you suck around the carotids at the time of cardiac ejection when the blood's coming out. You can enhance the effect on pain reflex, perceived pain, and ERP to pain using this method. We conducted an imaging study on actually pain effects or heart timing effects on pain some years ago. We were measuring lots of physiology in the scanner, including beat-to-beat blood pressure, skin conductance, ECG. We were presenting very brief electrodermal shock stimuli, either on systole around the T wave or on diastole or pre-systole around the QRS complex. And what we found was that if you present a pain stimulus on the heartbeats, you get an attenuation of the normal blood pressure response to the shock stimulus. And you see that for both components of blood pressure. So systole interacts with the processing of shock. The cardiac signal interacts with the processing of shock to inhibit the autonomic reflex that goes with the shock experience. And the brain correlates of that were seen as follows. Firstly, there's an inhibition of activity, a relative inhibition of activity within insular regions during this processing of shock stimuli at systole during the cardiac firing, baroreceptor firing. There's also a relative inhibition of activity in the dorsal brainstem, here dorsal pons, but also going up to PAG. And an opposite effect was seen in amygdala. So the amygdala seemed to be enhancing its response when pain was presented at systole. So this study gave us, if you like, the first look with neuroimaging to show that the processing of salient external stimuli appears to be gated or influenced as a function of cardiac cycle, of these signals that occur phasically from the heart. And the brain regions involved in suppressing this pain response, as measured in this case by an autonomic reflex, include insular and dorsal brainstem and amygdala. And the amygdala seems to be doing the opposite thing to insular and dorsal brainstem. So that got us interested in this whole area. We wanted to know whether we could use this effect in other ways, and whether other types of stimuli were affected by cardiac cycle, particularly salient emotional stimuli. And the next set of experiments we ran, we presented people with emotional facial expressions either on systole or before, and found the following, that if we present disgust or happy stimuli at systole compared to diastole, we get an increased slowing of heart rate, and that's significant but small. There's about a 1.5% shift in slowing of the heart. And only for disgust stimuli did we get a change in the rating of disgust stimuli, and that was very small effect, but significant. We looked at the brain areas that seem to be mediating this effect of heart on the processing emotional faces, and found the periaqueductal grey region predicted the heart rate changes, and to some extent the lower rating in disgust stimuli, and particularly orbitofrontal cortex also sensitive to the changes that systole evokes on the processing of disgusted faces. So this study showed, beyond the pain observation, that the effects of cardiac cycle on disgust, as manifest by evoked heart rate response, the slowing heart rate, and on subjective ratings, which were increased when disgust was presented at systole, but the effects were very small. And there are corresponding changes in periaqueductal grey, orbitofrontal cortex, and there are also effects, at least for the heart response, to happy faces. That experiment, we didn't test first stimuli, and that was a big oversight, I think. And so we went on to test the response, or the interaction between the processing of fear faces in this case and cardiac cycle. And it's an oversight because I think the data on the attentional blink test, which I'll come to soon, suggested that fear's got a close relationship to anxiety. We know arousal, cardiovascular arousal contributes to anxiety states, and we wanted to get at those mechanisms. So we repeated the same experimental paradigm using fearful and neutral faces presented at systole and at diastole, getting people to rate the faces a few seconds later. And what we found, as I said earlier, was that the processing of fearful faces at systole was enhanced. You got an increased rating of the intensity of fear in the face if it's a fearful face, and no effect for neutral stimuli. And that effect seemed to be mediated by changes in the amygdala, which reflected an interaction between heart timing and emotion. So enhanced response to fearful faces during systole in right amygdala, a true interaction in left amygdala. And actually that effect in amygdala correlated with the individual subject differences in trait anxiety score. So there was a relationship between this process of psychophysiological interaction between heart signals of arousal and the processing of potential threat signals or fear stimuli. Let's start to introduce this study. Used an emotional attentional blink test to look at the processing of fear and other emotions during a period where it's there's a lot of pressure on attentional resources and perceptual resources, and usually emotional stimuli break through more frequently than neutral stimuli. And when we timed the presentation of this target to systole and diastole. So we compared the effects of heart timing for neutral, happy, disgust and fearful faces at that time point, and showed that the detection of fear but not other emotions, and perhaps an opposite effect for neutral, that fear stimuli were much better detected when presented concurrently with the cardiac signal. And the individuals differed in the extent they got this effect. Some people going up to 25+% difference in the detection of fear at systole. So fear detection is also enhanced at systole. Emotional phases break through the attentional blink. Cardiac cycle modulates the effect for fear with enhanced processing of fear at systole, and there's no effects on other emotions, and possibly an opposite effect for neutral phases. We wondered whether this heart timing effect on threat stimuli was clinically relevant, and we've been conducting a large survey of patients accessing secondary care facilities, looking at the differential processing of fear versus neutral stimuli on and off their heartbeat, also doing measures of interoceptive ability and other signatures of emotional vulnerability or anxiety disorder likelihood. But we also did a lab experiment on spider phobics that also pursued this issue of whether heart timing can change or influence emotional processing. So we conducted a computerized exposure therapy to spiders as fear stimuli, presenting pictures of spiders at systole for some subjects and at diastole for other subjects during repeated exposure treatment sessions. A third group of subjects just saw pictures of spiders irrespective of when they were presented in the cardiac cycle. So you know, a 3-second presentation as opposed to a 150 millisecond presentation. What we found initially was that we had a lot of dropouts in the group that spiders were presented at systole. They found the spiders. This was a pilot. This is pilot data on the first 30 subjects. We've been repeating the study on the larger group of participants. So the group sizes are quite small in this group because we had 3 dropouts in the systole group. There are only 7 subjects, but those 7 subjects who had the stimuli presented at systole, by the end of the exposure sessions, were more likely to approach a mold of a spider, a kind of spider skin, real tarantula skin, than people that saw pictures of spiders at diastole, or this control group, surprisingly, who just saw pictures of spiders irrespective of their heart cycle. So this pilot data is encouraging. It suggests that there's better processing of spiders if you present them at systole, and surprisingly better than if it crosses systole and diastole. Presenting spiders at systole led to greater approach behaviour in the final session, and at least it's a kind of proof of principle study that suggests that the coupling of heart to anxiogenic stimuli might be a target for interventions, and the way we can think of interventions is not just in this biobehavioural way, but we can potentially use blood pressure drugs, for example, to help certain individuals with anxiety. So fear perception and detection is enhanced by cardiac afferent signals. It's the opposite to what is seen for pain. And I'm saying that, but we haven't done a study concurrently of both the pain and the fear. We're just rounding up a behavioural fear conditioning experiment that may address this issue a bit better. If you have a faster, stronger heartbeat, you bias your perception towards processing threats. At least the data that are presented show that. And there is this relationship with anxiety, and it offers a potential for therapeutic interventions. How long have I?
Maybe 5 more minutes.
Okay. I just want to say a few things about the concept of interoceptive prediction, because it is relevant. I mean, clearly, there are differences in threat as a predictor of potential damage to self, whereas pain is actual damage to self. But the concept of interoceptive predictive coding is being is emerging in the literature from a number of groups, and people are getting quite interested in the idea that the prediction about the internal states of the body is relevant not only to emotional processing, but has a relationship to self-representation and sense of presence and internal agency somehow, allowing the building up of other aspects of consciousness. This kind of relates what I've said about anxiety a bit further. It's a model of panic attack from Dave Clark, where an individual feels a twinge in their chest, and that makes them a little bit anxious, and the muscles tighten up and they start breathing heavily, and the heart races a bit more because they've become more aroused, and they feel that and think that the heart is going to stop, that they're going to die, and it adds to more tension and anxiety, and this vicious feedback loop can not quite be stopped when you stop and monitor your heart even more intensively. And what's going on is actually not so much problems with the sensation of bodily signals or the intensity of them, but with the interpretation of them, or a misinterpretation of them, or the initial trigger being an unexpected change in body state, but something more goes on to lead to a panic attack. And actually, many people have highlighted the relationship between unexplained arousal and anxiety. So Martin Porras and Murray Steen proposed this insular view of anxiety, whereby they argue that the insula is a comparator. The premise is that individuals who are prone to anxiety show an altered interoceptive prediction signal. So they have an augmented detection of the difference between observed and expected body states, so what they experience and what they expect their body to be doing in terms of feedback and arousal. As a consequence, increased prediction signal of a prospective aversive body state triggers an increase in anxious effect. So they're coupling the unpredicted, unexplained arousal to anxiety. That kind of idea that the expectation of what your body is doing is also embodied in a proposal by Tony Singer and others about how risk and uncertainty is processed, but also relating, again, the same insular-based body mechanisms of prediction and comparison to how we empathise to other people. We know what our body state would be doing if we're in a particular emotional state. We can make a prediction of that and judge someone else in relation to that prediction. To a degree, the mismatch between perceived body state or expected body state and observed body state can be seen in clinical groups. This shows a recent study we've been conducting in adults with autism, looking at how well people perform a heartbeat detection task. So this, if you like, is an objective measure of interoceptive sensitivity, and how much their lives are affected by autonomic symptoms or symptoms from the body. And neither the score on these questionnaire measures of their interoception or the heartbeat detection task predicted day-to-day experiences of anxiety, but what did was the mismatch between interoceptive score on questionnaires, subjective measure, and interoceptive accuracy, the objective measure. And that predicted trait anxiety in the autism group, called the mismatch interoceptive traits prediction error. And it also predicted deficits in empathy in that group, suggesting corresponding also to what Tanya Singer proposed in relation to prediction and empathy. Predictive coding models have extended to look at aspects of self-representation, presence in environments, agency and emotion. This is a model from Anil Seth relating internal agency, autonomic, interoceptive prediction, and both a sense of self that builds up from agency and a sense of presence in an environment. And the link between interoceptive ability and representation of self can be seen in other contexts. This is the rubber hand illusion. If you see a rubber hand being stroked in front of you while feeling your own unseen hand being stroked at the same time, you may get the illusion that this rubber hand is part of your body. You're less likely to get that illusion if you score highly on tests of interoceptive accuracy on heartbeat detection tests. This is Manos Sakharis and his group. So you score less if you're a good interoceptor on the question, I felt the rubber hand was my hand, and other more objective measures of getting the rubber hand illusion, this illusion of body ownership, also show lower values if you're a good interoceptor, consistent with the idea that a stronger internal representation of self protects you against illusions of body ownership. We've been doing virtual rubber hand illusion with virtual reality, and what we've been doing is adding physiology into the picture, so the hand pulsates in time with the participant's own heart rate, and that enhances the illusion. You get more enhancement of the illusion if they are a good interoceptor. Suggesting that internal physiological signals shape body ownership in other ways to always negating them. I am going to round up now. The insula has been proposed to have this representation across its posterior to anterior dimension, whereby primary representation of body states occurs in the posterior regions of insula. As it's integrated, the signals, the representations in insula are integrated with other aspects of environmental and physiological functioning. You get an enriched representation of selfhood, according to Bud Craig, in anterior parts of insula communicating with singular ventromedial prefrontal cortex and other prefrontal regions. And this year, Lisa Feldman Barrett and Kyle Simmons have proposed that anterior insula, which is agranular cortex in nature, is the source of interoceptive predictions, which whereas granular cortex has this primary representation, and somewhere in between, in mid-insular dysgranular cortex, you get the generation of prediction errors through this comparative mechanism. One of the issues with interoceptive prediction is the notion of cancelling out of self-related signals. We see it with pain. So pain on heartbeat is felt less strongly than pain between heartbeats, but we've also seen it with other types of stimuli. We remember stimuli less well if they're presented at systole, these are words, than at diastole. Actually, interoceptive accuracy protects against this detrimental effects of heart timing. But it's consistent with the idea that heartbeat signals are self-generated and cancel out, if you like, other signals. But that cannot explain the effects we see for fear, because they're going in the opposite direction. So there are two processes going on. It's not everything's inhibited by heartbeats, because that's a self-related stimulus. In this case, the fear is doing something else. And other people, so this is from Talan Boudry's lab, have shown that heartbeat-related neural signals, in this case the heartbeat evoked potential, enhances the processing of fine gratings at the limits of conscious perception. So a strong heartbeat evoked potential will make the likelihood of you seeing this fine stimulus greater. So there are a couple of paradoxes, but I just want to round up by saying the contents of consciousnness, that's at least the perceptions that you see, seem to be influenced by signals from the heart, and we're drilling into it by looking at specifically the timing effects of heartbeat, baroreceptor afferent information. And the perception of threat is enhanced, the perception of pain is inhibited by these heart signals. And that may relate to differences between a challenge to self-integrity being predicted by threat stimuli compared to an actual challenge to self-integrity corresponding to pain. But as we've said, there are other types of stimuli that don't really explain that difference. So physiological signals differentially contribute to emotional related perceptions. It kind of means that your whole experience of the world is fluctuating, at least in time with the heartbeat, and there's some evidence that other internal signals also influence how you sample the world. And there is this question of whether predictive coding can truly explain these phenomena, because it's not all cancelling out due to descending models of self meeting upcoming representations of your environment. So there's this other issue going on, which is the heartbeat signal in the brain represents an oscillation upon which one can load kind of perceptual work. And there's a whole area of understanding brain oscillations in perception that could relate to. So thank you all for listening. I've kind of left a rather inconclusive interpretation of the data we have, but I think really the notion that physiology affects how we perceive the world in ways that we are not aware of, but we can show experimentally is an interesting finding, and the differential effects of heartbeat signals in this case on fear compared to other types of stimuli, I think is got real clinical relevance as well as relevance to neuroscientists and philosophers. Thank you.
Thank you very much for a very stimulating and provocative talk. So we have time for questions.
Fascinating work. A comment and a question. There already has been a clinical observation about the reciprocal relationship between fear and pain. They tell the story that in the invasion of Italy in the Second World War, they had these soldiers who were gravely wounded, and they were still under fire. And it wasn't until they were at safety that they felt pain.
Right.
The question is this, clearly a lot of what you told us depends on an intact reciprocal relation between the brain and the heart. What happens in people with a high cervical lesion when most efferent and efferent connections are disturbed?
The one study we've done on people with spinal cord lesions was a fear conditioning study. We conditioned people to emotional faces, anger faces, and some of those faces were associated with a shock above the level of the lesion, sensory level of the lesion. We'd also tried to do conditioning below the level, and we actually showed an enhanced brain response to threat in those patients. So they seem to be more sensitive in terms of the neural activation to the presentation of conditioned threat stimuli than controls. We saw a physiological effect in both controls and patients. The physiological effects in patients was related to the parasympathetic innervation of the heart, so we got heart rate change to threat. But I guess the outstanding observation for us is that there seem to be changes in the brain responses that would suggest that they would be more sensitive to painful stimuli following the high spinal cord lesion. In terms of other aspects, I mean, there have been a lot of criticism of peripheral models of emotion based on the fact that you don't really see convincing changes in the emotional behaviours or rich lives of people with high spinal cord transections, other than what one might expect from disability and pain and those kind of changes that follow a traumatic injury. So it was surprising to us. We wanted to model that particular afferent pathway, and if anything, it kind of went in an opposite direction to what we had expected.
Thank you.
Thank you.
I guess this is a question pertaining to ecological or external validity. I mean, the pictures that you show are two-dimensional, and I'm wondering if you think that some of the effects that you're looking at, I mean, in addition to videos, if you added a smell or if there were other stimuli involved, if you would see something, you would see a facilitation of the kinds of effects. Would it be that simple that you see, or would you expect differences in that?
We haven't. What have we done? The most enriched way we've been exploring these heart effects is using virtual reality with looming stimuli towards people, but they're still just balls flying at people in a virtual environment. No sound, no other associated or contextual things other than plain room and things flying at people. And there we get an effect with a particular size and speed of a looming stimuli. Which, I mean, we're still in the process of writing it. We have explored other types of stimuli. We've used, I mean, I was just showing the face stimuli, but we've used kind of non-specific shapes for fear conditioning. I alluded to that. We're also looking at the difference between the shock, the kind of pain stimulation, and the threat. And it became quite a complex study because we had to do multiple counterbalancing of stimuli on systole during the learning phase, and we're looking at fear extinction as well. So we had multiple stimuli within that one experiment, and that looks like there are interesting real effects of heart timing on the both the learning and extinction phase, and which is. The extinction bit is kind of consistent with the pilot data we had on spider phobia. We tried to use sounds as a stimulus set for, and we didn't get an effect of heart timing on processing of sounds. We were, partly because the sounds were so short that we're playing, but yeah, I think that may be the reason, but I can't say for certain. People could recognise that is that kind of short sound that was a particular emotion. They could classify the sounds okay, but they probably weren't really naturalistic in the sense you'd hear kind of fear response normally.
Yeah, I was just thinking about more complex stimuli that have all the different dimensions. If different dimensions, like in the case of nausea or fear, if you see somebody in front of you having their leg cut off, and you can smell, all of those things. If those kinds of experiences, if there would be a facilitation of the kinds of effects that you would see.
He's combining two types of disgust, the faint and the nausea.
Well, but
in that
yeah,
picture of yours.
well, no, exactly. I guess anyway.
I mean, certainly it augment the feeling states that these would evoke, whether it could then speak to the heart timing effects, which I'm not sure. Well, we haven't pursued that yet.
Stuart? I have a question going back to the original philosophical question that you posed from Greek philosophy about whether the fear and emotions, whether they originate from the brain and body. And a lot of the models you presented along the way, since those first slides, incorporated somehow some cognitive or some sort of top-down assessment or appraisal of what's going on. And I'm wondering, it just made me wonder what happened if you sort of lesion that out from these models, what you might predict. One case sort of occurred to me, my area being in sleep, that there's an interesting case where there's a phenomenon called night terrors, where they're in very, very deep sleep. There's no processing of external stimuli. There's not much evidence of any sort of consciousness or dreamlike content or anything like that happening, but people will wake out of from sleep with extremely elevated heart rate and extreme sensations of fear. But it seems to be in the absence of a lot of the elements that were presented. So I was wondering, what you thought about how that speaks to the sort of original question of the origins of fear and the sort of brain versus body sort of argument, and how central then the cognitive appraisal of what's going on in the body might be for these models.
That's a very interesting point. I mean, I think there is an appraisal whether or not it's conscious or declarative or explicit in a classical way. I mean, when detecting a fear stimulus, the detection is undoubtedly triggered by the features that you're seeing, but often the perception is well before you actually make sense of that in any way you can explain to other people. And so with experiments that I haven't presented where we have masked fear stimuli and get the autonomic response and show differences in brain regions so that we know control aspects of fear-related motivation above and beyond autonomics, we still get everything but that explicit declarative conscious aspects of fear to what we think are subliminal stimuli. The only other area that we've been exploring has been the idea of subconscious rumination and effects of stress that last through the night on physiology, and how that then impacts on how people feel the next day. Is slightly different to the area of work. It's related to what we're doing. We're measuring physiological signatures of anxiety and seeing them in sleep as well as in wakefulness, and how they persist during sleep. Determines subsequent kind of resolution or otherwise of anxiety.
So a conscious sort of top-down appraisal may not be requisite then necessarily to feel anxiety or fear.
I think that's probably true. I think it will come down to aspects of definition or thresholding of what you call a feeling state and what your behavioural measure is, at least from my perspective.
Yeah. You showed that the evaluation of an emotional expression varies depending on the cardiac cycle. So you present the emotional phase during systole versus diastole. I'm wondering how much attention varies across the cardiac cycle, because you could imagine that maybe most proximately it's actually changes in attention that are driving the differences in the evaluation of the emotional expression.
I don't think it's. I think it's relatively hard to argue that because we're seeing a specificity. I mean, the strongest effects for fear that were 10% shifts in the evaluation, about 5% shifts, and we're getting very small shifts for any other emotion. Because of that specificity, I don't think it's a non-specific attentional effect. So if there is an attentional effect, I mean, there you go. There are brain regions that are like locus ceruleus that have neuromodulatory functions. Locus ceruleus projects noradrenaline throughout the brain, and noradrenaline is a chemical that does modulate aspects of attention and attentional focus, and will enhance processing of salient stimuli when it's released in the context of emotions and arousal. And this is basically showing from an animal experiment that the activity of norepinephrine, noradrenaline cells within this brainstem area that projects these around the brain is related to cardiac signals. So you get more activity in these cells at a particular phase in the cardiac cycle compared to other phases. So to some extent, I think you're right. I think there are aspects that could be called attentional that that are affected by cardiac cycle. And I think that could be an explanation to some extent of the work of Talan Baudry, where you have a heartbeat evoked potential determining whether or not you see a very low level stimulus or not. So the magnitude of an MEG signal that follows a heartbeat. So an oscillation, if you like, if it's a strong a high magnitude oscillation, then you're more likely to see the stimulus. And those kind of data fits with other data that suggests that if, the pre-stimulus state of a brain region predicts whether or not you perceive a particular aspect of a stimulus or not. And I think all of that could be called attention related. What I think is interesting is the way in which it seems selective for particular classes of stimuli or compared to others.
And I think Harrison had first.
I'm interested in your most naturalistic stimuli, the ones where you're showing people gruesome videos. And I kind of, you first kind of sell this insula as being related to your interoception or your bodily feelings that are a result of these videos. We also could kind of wonder, especially how you describe it later with Singer's work, that you're imagining what it's like to be that person eating rancid food, or you're imagining how that rancid food would taste. I wonder if there are direct causal manipulations of actual body states by invoking feelings of nausea or tightening of the chest or whatnot, and whether or not you can separate these very complex empathetic perhaps stimuli from the bodily sensations that they evoke.
So there's a long tradition of injecting people with adrenaline and things like that to change body state in different contexts. And the Chapter and Singer experiment was the classic one, where people were given adrenaline or I think placebo in different contexts of social contexts. I mean, you're right that those discussed stimuli generally, or at least the nausea ones, are kind of social, empathetic. The surgery ones, some of them you don't see the person's face, others you do, and you can certainly relate to it. And I'm sure part of the element is that embodying what you're seeing as though you were the person that you are seeing. There isn't yet, isn't currently a particularly good way of lesioning someone, stopping their autonomic responses in a way that would make them feel normal, but block the change that occurs in that context. We have looked at patients with autonomic failure, pure autonomic failure, who have a peripheral neurodegenerative disease that affects autonomic function to the point where they wouldn't be able to generate any emotion-related autonomic change in heart rate or stomach. But they're an unusual patient group who are middle-aged and beyond. We have looked at differences in brain and responses in them, and they show some attenuation of higher social cognitive functions, but not much else at lower level emotional functioning. So we have thought about different drugs we can give to people to block all their autonomics. A few years back we could have done that, but we can't now.
Chris?
Yeah, I sort of, I'll ask one question anyway. I guess I'm curious about the relationship between individual differences in interoceptive sensitivity or awareness and individual differences in autonomic volatility. And to what extent people who are higher in interoceptive awareness have a sharper representation of what's going on in their body, or is it that they have more signal to listen to because their autonomic nervous system is more active?
So the tests of interoceptive accuracy, I think we're calling it now, because we've decided to rebrand awareness as being the metacognitive measure of how well you know you're performing on the test, you know, rather than how well you perform on the test. So Olga Pilatos, using these Chandri heartbeat counting task, has shown a relationship that people that are good at heartbeat detection at rest in that counting task tend to have stronger evoked responses to stimuli, emotional challenges and things, which is kind of consistent with the idea that they're more attuned to their body state by having a kind of richer larger range of experiences, and they're tuned into that a bit more. But I'm not sure if it's a particularly straightforward prediction, but there's evidence that it's there.
And if that's the case, I mean, could you imagine sort of like maybe some, I don't know, clinical applications where it changes in posture, for instance, where you can reduce the autonomic signal, at least cardiovascular. You could take a high person who is high in interoceptive awareness, and all of a sudden you change their posture such that they're not feeling their heartbeat as the signal isn't as strong anymore. Would you then expect sort of a corresponding reduction in interoceptive awareness, or would that just sort of, would their ability, their sharp representation overcome that?
Secondary supervisor for someone that's done a whole load of experiments like that on tilt tables and things. And you can get changes in that. I mean, I think the aim of these tasks is to get really a kind of baseline measure of a constitutional difference among individuals, rather than a within subject measure of changes in their daily experiences. Again, Olga Pilatos with the counting task has shown that if you're hungry or have an empty stomach, then your interoceptive sensitivity changes. Certainly, if we're thinking about baroreceptor mechanisms, then posture is important for that. But at the same time, there's a counter argument in saying that these tests aren't that strong in terms of many psychometric properties, such that some people will say that they feel their heart beating because it's thumping against their chest wall, or they're feeling it in their fingers, or a pulsation in their neck. And they've got some sensory correlates of what they've learned to be their heart, and that might be a strong enough signal to base their emotions on, irrespective of what's coming up through the classic interoceptive neural routes.
Yeah.
You pointed out how difficult it is to reduce the autonomic status pharmacologically, but some of the guru masters managed to really alter the autonomic nervous system. Have you considered using some of your paradigms on these subjects?
We tried to do a study which looks at yogic breathing.
You have?
We tried. We ended up expanding the group to incorporate divers and woodwind instrument players, and ultimately, so trained breathers of any sort, and it ultimately didn't prove a fruitful study from that perspective. It proved interesting from other perspectives. No, but I have been thinking about something that relates to this idea that your physiological state affects your perception and attention and things like that, which anecdotally, people that can change their pupil size at will is kind of an interesting thing to study, because I'm still not sure what a large pupil, everyone measures pupil as a response, but I'm sure it has some kind of effect on perception. In the study, they measured pupil size and didn't show an effect of pupil size on what they're measuring here. So I'm interested in pupil size partly because it seems to be coupled to respiratory cycle as well, and the idea that you've got one physiological oscillation going on that affects processing of emotional stimuli, and if a larger pupil makes you relatively more sensitive to the low frequency aspects of a facial expression compared to the high frequency aspects, and this high frequency has been associated with identity and lower frequency with some of the aspects of facial expression, you might get a shift in processing of emotional faces. It'll be very subtle, but you might get it that relates to the respiratory cycle, which if coupled at particular points in time with changes in cardiac cycle, might be interesting to see what those points in time actually do to perception and whether they. So we've been thinking about getting people that can change their fetal size just to see at a basal level what that does to aspects of the process.
Thank you very much, and I think with this we can conclude the session.